Good evening, everybody. How are y'all? Sorry, I'm having issues with my webcam, so it's not allowing me to show the video myself. I'm sure y'all are all happy about that, but I do have uh, I think our webcam's going out, so that's part of the problem. Before we get started tonight, just wanted to kind of go over some stuff. I just wanted to make sure that everybody understood that you all need to check your grades on JB Learning. I've only had one person take chapter, the last class, the cardiology class. Everybody, one person, and there's 13 people that have not taken the chapter prior. So it's past time for that. Remember, you only get one per module. So y'all need to check your grades because tests are mandatory in this class to be able to pass. I don't know if some of y'all have forgotten that, but a lot of issues have been resolved, but if you don't take the class, if you don't take the test for the class, you're probably not going to pass. So please take the time and look into that to go look at your grades. Everything's up to par until everything's taken care of until tonight's class. So y'all remember I gave everybody an extra 24 hours on the last cardiology class because of the weather, and then I was sick. So just wanted to let y'all know about that. So diving off into this, tonight's neurologic emergencies. I like this chapter. It is, to me, it's pretty cool because there's a lot of things that affect the brain, that affect us in general, that causes us to have some issues, some small problems, some things, and that you may not have realized that is related to the neurologic side. But we'll rough off into this. So we'll go over tonight when we talk about medicine. We know this has been propped up there before. Medicine applies the fundamental knowledge of basic emergency care and transport based on the assessments and finding of acute ill patients. Talk about neurology, and we'll go over anatomy, presentations and management, how to recognize the decreased level of responsiveness, what it looks like, kind of how to understand, are they sluggish? We'll talk about seizures and strokes. We'll also talk about assessment and management when we dive off into stroke, transient ischemic attacks, which is a stroke. We'll go more into seizures, status epilepticus. We talk about headaches. So stroke is the 5th leading cause of death in the United States, leading cause of the adult disability in the United States. So that's a big freaking number. Does anybody by chance know what the #1 leading cause of death is for in the United States? So I'll tell you that's slip, trips, and falls. Strokes are very common in our geriatric patients, most of the time in our elderlies. It is a contributing factor for a stroke to include into the family history. So that's the reason why we want to make sure that we ask a very good assessment. We do a very good history. We ask the questions when it comes to past medical history, any family issues. Is your either parent have cardiologic or cardiac, neuro, or any cancer, anything like that? Those are things that helps build our assessments. We do have new treatments are available for strokes. They are growing and changing every single day to where it's improving the life of catching these strokes in time. We only have a certain small window once we recognize these in the field, but there are some treatments that are available that help reverse the stroke. We'll talk about the anatomy, physiology, and pathophysiology, stroke, seizure, status epilepticus, and that versus a headache, and the neuro part. So the biggest part when we started to go in here is our decreased level of responsiveness. When I ask them questions, I don't get precise answers. A lot of times in stroke patients, you get some confusion to where part of their brain's not working. So if I say, sir or ma'am, can you tell me what today is? And they may be like, purple. Well, no, I'm not wearing it, but that's a pretty color. But at the same time, as you may also notice some sluggish of one side of the body, you may notice some facial droops. Seizures, we have to be very cautious of. We know that they can cause head trauma from them convulsing and striking their head on a hard object. Ooh, words are killing me tonight. And then we'll go over strokes a lot more in depth further we go. So does it seem like we just keep repeating these? Why are we keep repeating these? Okay, so seizures and altered mental status may occur when there is a disorder to the brain. Oh, all right, cool. So seizures may occur as a result of recent or prior head trauma, a brain tumor, a metabolic problem, some fever, high fever, or a genetic disposition. So possible causes of altered mental status include intoxication. So even though that we may go to these patients and they're like, oh, well, he's drunk. Well, don't let that blindfold you, because what other injury mimics intoxication? Does anybody know? I don't want to say injury. What about
diabetes?
Yes, I should have said medical issues. Yes. So diabetes also mimic intoxication. So anytime that you have an intoxicated patient or that you assume for them to be intoxicated, you should always check their sugar. You should do a CBG check on these patients anytime you come across one. So be cautious in that. Head injury patients can cause seizures, hypoxia, strokes, metabolic disturbances. And we have different treatments for all of these. And they all follow, I mean, our head injuries are going to follow our trauma protocols, and strokes will too, depending on what side of the stroke and how long it's been. So those are some of the concerns that we want you to know what can potentially cause these. All right. So the brain is our computer for our body. It controls breathing, speech, and all other body functions, which we've talked about that before. It's just we don't have to key into things. We just know our brain's going to make us breathe. There are three major parts of the brainstem. I would make sure that you're aware of these. Have your brainstem, your cerebellum, and your cerebrum. The cerebrum is the largest part. Here's a picture right here. This will help you out. So as you can see, from the frontal lobe always to the back side of the skull, this is the biggest part here. Our brainstem is what connects into our spinal cord. As you can see, it comes up into here, and it does provide protection for our brainstem and then our spinal cord. So you have your cerebellum. That's this small little tube right here, this little oval shape. So those are the three parts of the brain. Even though we know it's well protected by the skull, we can have our swelling in here. We've talked about that, how the pressure can change, where there's blood that can create right up in here and create a lot of pressure. And once a part of the brain dies due to traumatic issues, it doesn't grow back. A lot of injuries in here affect the speech, the vision, any type of audible from a patient is affected right up in here into the frontal lobe. So we talk about the brainstem. We know that it controls a lot of different functions, but one of the most basic functions is breathing, blood pressure, swallowing, pupil constriction. The cerebellum controls muscle and body coordination. So that's what makes us look like we know what's going on. You have some of these neurological deficits that affect the walking. Some people have to very concentrate hard when they go to swallow due to maybe a bad car wreck where they've snapped their neck into a position and they've had injuries to the brainstem to where now they have trouble swallowing and some speaking issues. So those become damaged and you can't fix those. Those are an unfixable issue. But knowing which ones of these, the brainstem and the cerebellum, what they control, can kind of give you a better outline of potentially what is wrong with your patient. So let's talk about your cerebrum. It's located above the cerebellum and is divided into the right and left hemisphere. Hint, 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 I would make sure that I knew that. Each controls activities of the opposite side. So the right side of the cerebrum controls the left side of the body. The left side controls the right side of the body. The front of the cerebrum controls emotional and thought, and the middle parts control sensation and movement, and the back processes sight. So those are the particular, and those divisions, when they're divided, what they control. So if you go to somebody in a motorcycle wreck and they tell you that they're having trouble moving things, you know that the center part of their brain has been damaged or has a traumatic injury that could potentially reverse, or it'll always be fixed and to be damaged. In most people, speech is controlled on the left side of the brain near the middle of the cerebrum. Messages sent to and from the brain travel to the nerves. The 12th cranial nerve runs directly from the brain to the parts of the head. I would know that if about y'all about the cranial nerve. I remember that question from my national registry 20 years ago. All right, so the rest of the nerves join the spinal cord and exit the brain stem through a large opening at the base of the skull called the foramen magnum. At each vertebrae in the neck and back, two nerves branch out from the spinal cord and carry signals to and from the spinal cord. Ding, ding, ding. Look, here's a picture that helps us out. So on the figure, you can see it illustrates the intersection of the skull and spinal cord. So brainstem, now it breaks down into the spinal cord. All right, so the two nerves branch out of the spinal cord to each vertebrae in the neck. So now you start to see how it's branching out. It breaks down in here to this is part of your, this is the coccyx area, like right in here. So now you know landmarks of where we're at. Many different disorders may cause brain dysfunctions and may affect the patient's level of consciousness and speech and voluntary muscles. Brain is the most sensitive to changes of oxygen, glucose, and temperature. I would highly make sure you knew that also. What three things make the brain most sensitive? Well, oxygen, glucose, and temperature. Those three things are something that you need to know, and that it's widely important. A significant change in any one of these levels will result in a neurologic change. You may, if they become hypoxic, you'll notice a neurologic change. Their blood sugars, that is a huge issue. We talked about that a second ago when y'all pointed out that also mimics being intoxicated. But again, we can't rely on our general, be like, oh, yep, they smell that sweet smell. They must have been drinking liquor all day. Let's just check a sugar. That's an easy fix. We check their sugar and be like, oh, dude, this dude's sugar's off. We can fix this. So once you fix it, you start to realize things can change and come around. One of the most common complaints you will hear from a patient in terms of pain is a headache. I am a chronic migraine person. I get, before I was medicated over a year ago, after part of the TBI I suffered, I was getting anywhere between 35 and 40 migraines a month, and those were debilitating migraines. They started affecting my career, my job, my sights, my eyesight. It affected my hand movements. I couldn't function like I normally do. So headaches can be a symptom of another condition, or it can be a neurologic condition in its own. Only a small percentage of headaches are caused by a serious medical condition. And tension headaches, migraines, and sinus headaches are the most common types of headaches. So this one right here, tension headaches results in stress, a lot of workload. And a lot of times that you have the issues from migraines are because of the eyes, or you're just not hydrated enough. A lot of people come see me out here due to headaches, and it's, yes, I provide them medication, but at the same time as I make them hydrate. And upon the two being on board, you start to notice some changes. You see a change in their abilities and all that. So they have those issues. They're able to get out. They're able to take the medication and drink the water, and those headaches start to resolve over time. Tension and headaches caused by muscle contractions in the head and neck and are attributed to stress. We all get that in our own little ways. The pain is usually described as squeezing, dull, or an ache, and it usually does not require medical attention. I have been to the calls where, oh, I can't, my head hurts so bad, the room is completely dark, they're very light sensitive, and those are debilitating. I've been to other calls. I was woke up Monday night, and I think that's what started my headache because I didn't get any sleep, for a guy that woke me up because he had a massive headache. Well, y'all have to realize too that a lot of medication, we don't leave Tylenol and stuff like that. You're not allowed to bring that with you offshore. So when I literally say I'm like a CVS out here, I am. Plus, I have to regulate what kind of medication they go in. It goes in their bodies. So migraines are thought to be caused by changes in the blood vessels size and at the base of the brain. The pain is usually described as a pounding, throbbing, or pulsating pressure, often associated with nausea and vomiting, and may be perceived by visual warning signs such as flashing lights or partial vision loss. Migraines and migraine headaches can last for several hours to days. I think the longest one that I personally had one was about probably 3 days. Some are very debilitating, and then some that I can continue to work and you would never know that I had a headache. But that's part of the reoccurring migraines. In their classification, they're called cluster headaches. And those cluster headaches can be so bad that they debilitate you. I highly, highly believe in medicating these patients on the front end and hydrating them. Those are really the only things that we know that are going to fix those. So again, let's not get this confused. Sinus headaches are caused by pressure that is the result of fluid accumulation in the sinus cavities. So that backup of pressure is starting to cause a lot of pain, and the accumulation of that fluid creates the pressure. Patients also have a cold-like symptoms and signs of nasal congestion, cough, and fever, which nowadays that's considered a possible sign of COVID. So if you go in and tell them that, they're probably going to tell you, okay, well, you had to get tested. Any type of sinus headache is not an emergency related, but again, people still call 911 daily for those. And for the ones that live in the South and realize that that is a ongoing thing, that you always have the allergies, that's yes, that's just part of it. You get those sinus headaches. Some serious conditions, you may it can mimic the headache of the hemorrhagic stroke, brain tumor, or meningitis. So again, doing your good assessment, asking some good questions, and just trying to dig in to figure out what are you really doing here for and why did they call you. Those simple questions that we've gone over in the past can help you gain a good enough assessment to where you may be able to recognize, oh my God, is this a stroke? Have they been outside the country lately? You can check for meningitis. There's really no way we can check for it in the field, but we ask those questions and then we kind of can relate to some of the signs and symptoms of meningitis, and you can go from there. We talk about a stroke. You may hear it called a CVA, which is a cerebrovascular accident. So a CVA is very common to be said. You may hear like an ambulance or fire dispatch to be like, possible CVA. Well, at the same time as I laugh, it's like, why don't you, instead of doing these 10 codes, just say, possible stroke. But we use CVA because that's what it's originally called. So a CVA or a stroke is an interruption of blood flow to an area within the brain that results in the loss of brain function. So they just died. We're not able to get that information back. We can't just get those areas. We can't get them back full of blood. They've died and they have reverted to blood to other places. So there was two types of stroke. You may want to know this. This is an ischemic and hemorrhagic. Those are the two types of strokes that you will hear majority of anything else, and that's why they're broken down into this. So I'm going to dive off into what an ischemic stroke is. So an ischemic stroke is the most common. It accounts for 87% of the strokes. It does result from a thrombus or an embolus. Symptoms may range from nothing at all to complete paralysis. Arteriosclerosis in the blood vessels is often a cause. And here's a picture to kind of explain it. So you see right here is where the clot through. So the clot traveled all the way up to here and got into the blood and to the brain, and it clotted. Okay, well, again, we have to be able to recognize this. And if it's enough signs and symptoms that we see that, and it's early, and it's not like, oh, it happened at 2 o'clock in the afternoon, but now it's 11:45, they haven't changed. Now let's go see what's going on. Well, you only have 3 hours from the first onset of symptoms to get the patient to the hospital. So that's why strokes are also important, because they're time sensitive. We've got to get them there within a certain amount of time. So a hemorrhagic stroke counts for only 13% of strokes. We'll show you a picture too. The cerebral hemorrhage is often fatal. This does result from bleeding inside the brain. People at high risk are those who have very high blood pressure or long-term elevated blood pressure that is not tolerated. So those are our biggest risk of a stroke is basically it's untreated. Everything that you see is untreated. Is most time if you go to the doctor all the time, they're going to check your blood pressure. If you've got anything that's a little high, they will watch it and get you to come back in a little while, and then they may be treating you. I'm treated for high blood pressure. I think mine is weight-based. When I lose more weight, the less that I have issues with that. But I've noticed it on some occasions. I can tell that I don't feel so well because my blood pressure's gotten high. But again, that's just, unfortunately, I can say that's just part of the aging process too, is it's something we all have to deal with. So Berry aneurysms are common causes of hemorrhagic strokes in the healthy young people. This presents as the world's worst headache of their life. It does cause a subarachnoid hemorrhage. So you can see not real sure what this is. Not real sure what they're trying to show us right there. So a TIA, or a transient ischemic attack, is a stroke-like symptoms that go away on their own in 24 hours or less. This may be a warning sign of a larger stroke to come and is considered an emergency. About 1/3 of patients who have a TIA will experience a stroke soon. All patients with a TIA should be evaluated by a physician. If we know that they're having a TIA, they need to go to the hospital. And sometimes you may just have to tell them, you're like, listen, sir, I have to take you to the hospital. If you don't go with me, you can possibly die. and nobody's going to be able to find you. I understand that you don't want to go to the hospital. I completely get it, but I need you to go with me. I'm concerned about you, and your health and well-being is my utmost concern. And they may just up and go, or they may just tell you to do a few things and go away. So, but that's important, very important. Facial drooping is one of those visuals that we get to see. Facial drooping, you have sudden weakness or numbness in the face, arm, leg, or on one side of the body. You have a decreased or absent movement and sensation on one side of the body, and you lack of muscle coordination or ataxia or a loss of balance. So those, when you hear the commercial, I hear it on the radio all the time, no matter where I'm at traveling, talks about the stroke. And it says, he keeps saying over and over, I'm having a stroke, I'm having a stroke, I'm having a stroke. And the other guy talking to him doesn't realize what's going on. But that's the body's way of telling us, and they teach a lot of people by radio because people listen, they pay attention, and they understand that it's a very serious issue. And we want the general public to realize that, because the faster that they recognize these things, the faster and the better that we are, that we're able to get there to them by their side, get some lines started on them, get them to a stroke facility, and then they're able to either reverse it, continue on with life, see their loved ones, or it may have had irreversible effects. So that's why that there's a timeline on dealing with stroke patients. You do have sudden vision loss in one eye, or blurred or double vision. It does become difficult to speak or swallow when you're having a stroke, because it's that fine motor skills that we lose during a stroke. So you have your decreased level of responsiveness. You may ask them a question, and then 10 minutes later, they come back and say, yes, I have my boxers packed. What? You're just now answering that question? It's because that's how their brain perceives it, and that's how they answer the questions. So it may be a delayed response. You have aphasia, and aphasia is a difficulty expressing thoughts, or it's the inability to use the right words. You may have expressive aphasia, or the difficulty understand spoken words in a respective aphasia. Slurred speech or dysphoria, sudden and a severe headache, confusions, or dizziness. So when I first went to the doctor and started telling them that I suffered from migraines, that I affected my vision and all that, well, the first thing they thought is I had had a stroke. I had MRIs, I had CTs, I had CAT scans, and all of that was done to rule out the possibility of me having a stroke. Yes, it was very expensive in the process. I'm glad the doctor did it. It helped. It was able for me to pick up and get back into things. So even when they treat me for my headaches, I still have to do a MRI pretty regularly. So you're going to have some confusion and dizziness during a stroke, because their brain is not working like it should. So a lot of the normal auto functioning parts of the body is not in the norm, and they're having to regroup and try to figure out how to stabilize us again, might we say. So you will have weakness. They will fight you. They don't mean no harm at all, but at the same time, as you got to realize, it's that sometimes fighting with seizure patients or stroke patients that's not understanding, it's a battle, bro. You better have your game on. They do get restlessness, their tongue deviation, and they could go into a coma depending upon how severe that this bleed is. If it's not too severe, you may see them just functioning, but it's in a very low capacity. All right, so when we have a stroke on the left side of the hemisphere, it is a left cerebral hemisphere and may cause aphasia. Aphasia is the inability to produce or understand speech. Speech problems can widely vary. You have strokes that can affect the left side of the brain and can also cause paralysis to the right side of the body. So that's why it's so important for, and I say us, and I mean in the healthcare world, to figure out exactly what side of the stroke is affecting. A lot of times, if you have right-sided facial droop and right side arm or right arm weakness, you're gonna have left-sided issues. So that's one of those that we can pass on to the facility, and that those findings need to go into your reports because we have helped diagnose this patient with issues. So we want to be able to fix those things. And if we withhold that information from them in the hospital, it's not doing that patient any justice. So on a right-sided hemisphere, a stroke will cause paralysis to the left side, like we talked about. Usually patients will understand language and be able to speak, but their words may be slurred or hard to understand. Patients may be obvious to their problems. This symptom is called neglect. Many neglect certain parts of their vision. Neglect and lack of pain caused by patients to delay seeking help. So a lot of times your geriatric patients don't want to ask for help. They feel that they're bothering you. They feel that they're hindering you. And they feel that there's people out there that need you a whole lot worse than they are. So they will discredit the pain, discredit the issues that they're having, just base it off of, oh, it's just my health and da 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 da. Well, yes, I get that, but we need to make sure that that is the problem. So let us transport you. And a lot of these elderly patients don't like that. They don't want to. So you have to persuade them pretty hard. And you don't ever want to lie to somebody, but at the same time as you can say, hey, I understand that you don't want to go to the hospital. I truly do. But I need you to sign this refusal saying that you don't want to go. When you explain it to them, be like, okay, so you understand that by signing this piece of paper, your family cannot hold me liable if you die because you do not go and get checked out. A lot of times that changes the people's ideas. It does sometimes it's not. I've been to a house several times for strokes and I get a refusal all the time. And then the last time that I went there was with the coroner because they finally passed and the family was all upset. They were distraught. And I straight up told them, be like, look, y'all knew when he signed this paperwork that that was an issue, because when I do it, I'm like, accepting this, you can't sue us if there's any injuries and your families can't, because you're signing this, accepting that to be a potential result. So how you word your words may help us out a lot in getting these patients to the hospital. All right, so bleeding in the brainstem. So patients may have high blood pressure, and that's why we always want to be cautious of blood pressure, that we keep our eyes on that during transport. You may see some bleeding around the nose. A lot of times you get nosebleeds from high blood pressure, and it may be caused by the bleeding as a compensatory response. So it may just be one of those, okay, your nose starts bleeding every time your blood pressure is above blah, blah. Well, that's just a sign saying you know that. This may be caused by the bleeding and compensatory response, which we said that. A trend of increased blood pressure is an important sign, as the body must increase the blood pressure to get the blood to the brain's tissue. Significant crops in blood pressure may occur as the patient's condition worsens. Let me say that again. So significant drops in blood pressure may occur as the patient's condition worsens. Some conditions that may mimic a stroke, you have hypoglycemia, a postictal state, and a subdural epidural bleeding. So postictal, if anybody knows, this is a position that people become in after a seizure. They may be in the same thing after a stroke. They're just Most of the time they're sitting upright, they're shaking their heads. They don't really, they're not common with a lot of words, and they just sit there with like a 30-yard, like 100-yard stare, because their body has just been resetted, and they're trying to figure out what to do to, like, when they're powering their brain, they're powering their power back on. It's a slow process. All right, so in this figure on the slide illustrates intracranial bleeding. Trauma to the head may result in intracranial bleeding. Bleeding outside the epidural results, bleeding outside the dura and under the skull is called epidural bleeding. And bleeding beneath the dura, but outside the brain, is called a subdural bleed. So here you see this is on the outside, and this is on the inside. So seizures. A seizure is a neurologic episode caused by a large surge of electrical activity to the brain. It is a quick, rapid response. In the United States, it is estimated that 3.5 million people live with epilepsy. Seizures are classified into two basic: generalized and partial. So if it's generalized, it's generally in one area. Or if it's partial, you may have just the upper arms affected, you may have just the lower arms affected due to a seizure, or you may have a full body seizure. There's different types of those seizures. So a generalized is called a tonic-clonic seizure. And this results from abnormal electrical discharge from the areas of the brain, and it usually involves both hemispheres. Typically characterized by unconscious and generalized severe twitching of all muscles that lasts for several minutes or longer. So the longer that they seize is the more damage that they potentially have. So if we know that they're like, hey, they've been seizing for like 4 and 5 minutes consistently, we got to do something. We need to, call for ALS interventions. We need to get them there faster. We need that. We need somebody to show up to help us, because they need medication that can help stop the seizure, and we need assistance in providing care for our patient. So the absent seizure does not involve any changes in motor activity. This is characterized by a brief lapse of consciousness in which the patient seems to stare and not respond. So that, again, this is a 100-yard stare. So it is, they forget where they're at. They forget what's going on. They aren't remembrance. The consciousness is just, they don't recall a lot of things. They can pass out. They can be very dazed and confused. All those are telltale signs of a seizure. Being able to tell the difference between seizures and strokes, yeah, it's a visual thing, but how it affects the brain, you may get somebody that is in that, where'd it go? You may get somebody that is in that tonic-clonic seizure, but they're able to be snapped out of it. So a focal onset aware seizure. So these are no changes to the patient's level of consciousness. Patients may have numbness, weakness, dizziness, visual change, or unusual smells and taste. And this may also cause some twitching or briefing. So that when we start to get these focal onsets or any type of epilepsy that lasts for a long time, and it's been documented, this is where you start to get the service dog. You can bring service dog into Dallas. Sorry, I was thinking. So your service dogs will be more able to be gotten in this pool. I was watching a thing the other day about Dallas and their service dogs, where the lady turned it down, and you can't turn down a service dog. That is a big no-no. You may not allow pets in certain areas, but a service dog cannot be turned away from service. Now, that if you do that as a business owner, you're going to reap a lot of repercussion out of it. So these focals start to have these service animals that can smell them coming on, notice the body changes. There's a lot of service animals that also do for blood sugars. So those things are noticed and picked up that those animals are able to work with. So a focal onset impaired awareness seizure, the patient has an altered mental status and does not interact normally with his or her own environment. So some results from abnormal discharges from the temporal earlobe of the brain. Other characteristics may be the lip smacking, eye blinking, and isolated jerking. Patients may also experience unpleasant smells and visual hallucinations. They may exhibit uncontrollable fear or perform repetitive physical behaviors. So these are some of the things that they have to be learned about. They're not going to be one that we're going to pick up just because they're not acting right. It happens notorious all the time, and those are like visual cues that this patient's starting to have a seizure. Okay, well, now that we realize that they have these lip smacking and all that, we need to address that. How do we can help control that focal seizure? I have very, like my tongue hates this word, ARES. Patients may experience warning signs, ARES prior to a seizure. These can be visual hallucinations. They can hear things, and that's not talking about psychiatric issues, but they can have the issues of hearing a few things and all that. People with a history of seizures, they do recognize their ARES, that word, and usually take steps to minimize injuries such as sitting down a line. And that's where those dogs or service animals come into play. They help you see those, they help recognize that, and they can help prepare you to know that a seizure is coming on. ARES do not occur prior to every seizure, and not all patients with a seizure disorder experience these. I like to see these dogs, like they have mold dogs. They smell their noses 100,000 more times better than ours. So these dogs are able to smell these cues that these patients pass on, and even with blood sugars. And these patients go to these teaching centers to where they're taught, along with being taught, of how their dogs recognize things. What are their dogs' keywords, and how do they help protect you? It is a very cool process when they do these things. When a patient gets a new dog or they started the whole process, it's neat to watch these dogs work. That's why when you see these service dogs, respect the service dogs, because they're not only meaning is to just be there and be present, but it's to help protect that patient as they move on to try to have a normal functioning life. So a generalized seizure is characterized by a sudden loss of consciousness followed by a chaotic muscle movement and tone and apnea. They may exhibit bilateral muscle movements characterized by a cycle of muscle rigidity and flexation. That's your normal seizure jerks, the one with the flexing of the arms. Those are the ones that we're used to seeing there. It is typically less than 5 minutes. I've seen some that last up into the teens. They continually seize over and over and over and over. And the bad thing is you can't start an IV on them while they're relaxed because they're jerky. But at the same time, to me, it's easier to start an IV when they're in a seizure because their veins are constricted. I'm able to see them a little bit better instead of once they relax and everything's like, oh my God, I feel so much better because I'm not intense. And then they all are followed by that postictal state. And what we say is that's the non-responsive, that's the scared phase where they wake up and there's they went to bed and they started seizing, and their spouse woke up and was like, oh my God, they're seizing. And then when they wake up, there's like three or four firemen, 2 EMS personnel. So they're not used to having all these people in their bedroom, and they're like, what the hell are you doing in my house? So that's the postictal state that we refer to as, and then once you see that and you understand that state, you're able to pick that up a little bit easier and be like, oh, well, that's in a postictal state. They must have had a seizure. So those type of seizures are formally called a petit mal, and it's a petit mal is the absence of a seizure that may last just for a few seconds, and after the patient fully recovers with only a brief lapse of memory or the time event. The patients do fully recover. They may not remember what happened right there instantly, but over time they'll start to realize, oh, I remember this, I remember that. It's just like a pause button that's been pushed on them. And then once they reset and they're able to come back to their brain start remembering what they saw, they're able to pick up information and move forward. All right, so status epilepticus is a seizure that lasts more than 5 minutes and are likely to process to the status epilepticus. So seizures that continue every few minutes without the person regaining consciousness are lasting longer than 30 minutes. Recurring or prolonged seizures should be considered immediate life threat. We don't want them to continue to seize, but eventually they're going to use up all the oxygen in their body. Their heart's going to be tired. So getting them to a facility and watching how fast that facility reacts and treats them lets you just know how serious that is. Anytime that your patient starts to seize or you walk in on a seizure, you as a BLS and as EMT basics need to call for assistance. You need to have them reach out and help you out. Get that ALS care there. Here's some common causes of seizures. I'm gonna let y'all read that real quick while I grab me something to drink. All right, and as you look at this, these are some of the common medications that are used to control seizures. You may have your Keppra, which is kind of an old one. You have your Dilantin, phenobarbital, Depakote, Topamax, and Klonopin. The Tegretol. Topamax is also used to treat migraines and in higher dosages. That is also called Dopamax. I was on that for a long time. When I first got my migraines under control, I started forgetting a lot of things. I couldn't remember where I put things. I would be looking for my keys and they'd be in my hand. My vision deteriorated pretty fast once I was on that. So Topamax is kind of being moved off from this list, and more of the Keppra, Dilantin, and Depakote are the ones that you hear the most. That's kind of the normal seizure medications that you would see when you're on the streets working. So obviously recognize when a seizure is occurring and whether the episode differs from the previous ones. We may not know that, but if we've seen this patient enough, we know that, oh, well, Fred normally seizes for about 30 seconds, and then he's postictal, and then he seizes again, but he doesn't normally have more than 3 seizures. We're not going to know this if we're not familiar with this patient. But you need to recognize the postictal state and understand that the postictal state is due from a seizure, because not a lot of people are wanting to say, oh, well, I don't know. You hear a lot of that. And once they come around, they're scared. They're not able to recognize what's going on. They're very distraught too. Identify other problems associated with the seizure. If they may have caused some bleeding from them violently jerking around, that's okay, we understand. They may have caused some head trauma, so make sure you do a quick assessment, especially the head, the arms, uh, anything that may have come in contact with a hard surface. Be very cautious and look into that and see what that potentially is, or if there's an injury at all. So once the seizure has stopped, the patient's muscle does relax and become almost flaccid, and they just flop around. And the breathing becomes very labored because they used a lot of energy during that. A lot of stored energy caused them to dump that, and now they're tired. This may be characterized by a hemorrhagic or weakness on one side of the body, resembling a stroke. The postictal state is most commonly characterized by that lethargia and the confusion. And if the patient's condition does not improve, you should consider other possibilities underlying the condition. If it's prolonged, if those seizures last for greater than 5 minutes, that is equivalent to a priority 1 lights and sirens response. Some other agencies may call it something else like code 3, code 1. But those patients need to be addressed in the facility as fast as possible, or meet your ALS unit en route so they can also assist with getting this patient to stop seizing by medication reasons, or just IV and medications is what's going to help stop that patient's seizure. So a syncope, and so seizures are often mistaken by syncope, which is a faint. Fainting typically occurs while the patient is standing. Seizures may occur in any position at all. Fainting is not associated with the postictal state. There's a lot of reasons. Hang on, let me see. There's a lot of reasons why people may have a syncope episode. It could be related to a medical condition, can be related to stress at the same time. You may have some other issues, like if you're standing there for so long and you lock your knees while you're standing, that's a big no-no. They don't want you to do that because that's guaranteed to pass out. But being able to recognize them once you get to that patient's side will be able to help do a lot of different things when you go to your treatment, or you're going to have to reach out and call med control because this patient really doesn't want to go, but you're like, oh no, I saw him seizing. And the patient's in the background, I wasn't seizing, blah, 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 blah. Well, sir, I'm the one that witnessed it. I was able to assess you during the process, and you didn't remember anything when you came out of that. Those are some of those, you just learn those tricks over time to be able to use that part. So aside from a stroke and a seizure, the most common type of neurologic emergency that you're going to encounter is a patient with an altered mental status. So they are caused by hypoxemia, hypoglycemia, hypoxemia, intoxication, delirium, drug overdose, some unrecognized head injuries, some brain infections, body temperature abnormalities, a brain tumor, and overdose or poisoning. Patient assessment. I'll tell you what, let's take a break before we hit this. We will take about, give me 15 minutes I need to run and take care of something. So what is that? So 7:10, we will be back here. I need to run downstairs real quick. I just got a text message. I need to handle some business. So I will see y'all back here at 10 after 7, and I will start back with some questions if y'all have any. So give us just a minute.
was gonna run our own man.
So we need to have a baseline of vitals to figure out what's going on. So we have a significant cranial bleed. When we talk about these pressures, we may have some issues moving forward, but our vital signs are the ones that are super important. We need to be able to pick up on what the baseline is or potentially what has changed. If something has changed into their status, that's important. Blood pressure is usually high to compensate for poor perfusion in the brain. Unequal pupil sizes, sorry, I gotta stop something else. So unequal pupil sizes indicate significant bleeding or a pressure on the brain. Check the CBG or check a blood glucose level. That we need to be able to understand some other simple things to do if we look and we notice that there's been a one pupil is different than the other. Well, there could be some head trauma. We maybe have high blood pressure. We could have the sugar that's offline. We may have, that could be normal. That patient may have a normal blown pupil, but with them being may not be able to answer questions or a little lethargic or unresponsive, that may be one of those that we just have to deal with it until we're able to find somebody to ask those questions. If things seem to be normal, then we can continue with our process. But that's something that we want to continue to watch. So stroke assessment. So stroke scales evaluate the face, arms, and speech. So B-FAST is a very mnemonic that was used a lot. The Cincinnati Pre-Stroke Hospital Scale or the Los Angeles Pre-Stroke Screen are some of the ones that are the most, they're the biggest ones out there that you use. Obviously, our GCS, we need to know what that is. I'm not very familiar with the Los Angeles Motor Scale. I don't know that one to teach you that, but the Cincinnati and the Miami are the ones that I use the most. There is a awesome little video on YouTube about the Miami stroke screen. I highly recommend looking that video up. And if I can find it this evening, I will send that to everybody in Discord and let y'all watch that. It is a really neat way of detecting strokes. Some simple things that you may look for is when they talk about here, obviously we're going to have face droops. If get the patients to hold their arms or assist the patients to hold their arms out in front of them. If you help lift them up, be like, okay, listen, I'm going to move my arms. I want you to be able to hold your arms straight out in front of you. If you move your arms and one arm droops and the other one doesn't, that is a sign of a right or left-sided stroke. If their speech is affected, what we can ask them is say, hey, I need you to repeat things for me. Like, can't teach an old dog new tricks. They won't be able to do that because of that simple skill is affected due to the stroke. So the B-FAST, you can read that real quick. I'm gonna let y'all read on how to ask those questions and some of the things you can ask. So while I get something to drink. One of the most important ones that I see on the screen is when we talk about time. When did the symptoms first appear? Write that down. When the family realized what's going on. And then don't delay transport an appropriate stroke facility. Make sure you transport them to that stroke facility because they're gonna have to get that stroke screen and potentially some other medication as fast as possible. What is bad is we only have a 3-hour window. So when you have these elderly patients that may live with their kids, not in assisted living, and I'm not a big fan of, assisted living or nursing homes, but understand that if they say, well, I left them at 9 o'clock this morning and they were fine, I talked to them at 2 o'clock and now it's 6 o'clock and something's wrong. We don't know when that first came on. So we still have to act like this is a very new onset, but due to the timing, they may not be able to reverse that. It may be outside of that window. Here is the Cincinnati pre-stroke screen. You can ask these things into a normal, yes, no, or is this a normal response? Both sides face move evenly, yes. One side of the face does not move as well as the other, and it droops. So those are the questions that we look for. This should be in your book on 18-4. And then here is the Los Angeles pre-stroke screen. This is a check yes or no box. So this is something that you may have to have in a field guide. You may be able to use some notes, or you may be able to pull the stroke screen out of your book bag because you printed it and laminated it. But it's just a simple yes, unknown, and no question that you can mark yes or no and move on, and that you can pass that information on to the facility as you get there. Again, this is a very good initial screening to where we can have a baseline. Did it change en route? Well, we don't know. We'd have to redo the scale. I don't like that one. I don't want to teach you that one. So all patients with altered mental status should have a GCS. And remember, here's our GCS. And the best that we can get is a 15. Even if you see right here, even if a deceased person, they still get numbers. They still get a 3. Now, right here, remember, 8 or less, you must intubate. So they're not going to be good. So 13 to 15 may indicate mild dysfunction, although 15 is the score a person without a neurologic disabilities would receive. 9 through 12 may indicate moderate dysfunction. So you potentially know what your status of your patient is when you have a good GCS. Knowing if you have a patient that's less than 8, you must intubate. That's just a key thing that I've known ever since I've been in medic school. But having that information, and you're like, oh God, I remember Chris saying, if it's less than 8, you must intubate. Well, you may not be able to, but you can drop that airway adjunct. So the adjunct will help open that airway, and now it's secured the airway to where you can go on from there. So knowing your range will help you also with these patients on your triage. So when we go to reassess, again, we reassess the beginning. We're going to do vitals. We're going to assess our ABCs. Watch carefully for any type of change. When you've had changes in these, and it doesn't have to be greater than 2, 3, 5, 10%. It's any type of change is something that we're going to have to notice. That is going to be a noticeable change that we look for. And again, if you've given the facility a report, let's say you were 10 minutes out, 15 minutes out, and you went ahead and called the hospital and gave them a report. If it changes while en route, you don't have to call them back. But as soon as you get there, be like, hey, look, we did have a change of status when we were about 3-4 minutes out, and blah, 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 blah. This is what it is. Those changes are okay, again, but you need to know, did they get good? Did they get bad? What direction did they go in? In most patients with a suspected stroke, physicians in the emergency department need to determine whether the there is bleeding in the brain. If there is no bleeding, the patient may be a candidate for a blood clot dissolving medication. If the bleeding is present, the medication will increase the bleeding with it will increase the bleeding and it can potentially cause death. Notify the hospital regarding the last time a patient was known to be without their current signs and symptoms of a stroke. That is that window. That's that 3 hours that I was telling you about. If we know at 2 o'clock that the family spoke to them and they were fine, so somewhere between 2 and 6, when you got called, something happened and there may be potentially signs of a stroke. So patients who have had seizures, you need to require definitive evaluation and treatment in the hospital. For patients who are having a seizure, protect them from harm, maintain a clear airway by suctioning, provide oxygen as quickly as possible, and if or any head or neck injury trauma is suspected, provide spinal immobilization. It is going to be very hard to try to C-spine and board these patients. So knowing that, even if you say, I'm just going to put a C-collar on them and the best I can do, I need to try to board them. When they start to have a seizure again, you need to un-Velcro them from the backboard. They can potentially break bones. We don't ever want to restrain them, but we need to protect them from harm, specifically their face, their head, placing something underneath their head that is soft, so they're not jerking. Never, ever, ever stick something in their mouth. One of the worst seizures that I ever had, I was taking care of this patient. I was trying to start an IV. They started seizing. I continued the process of trying to start that IV while they were seizing, but I kept hearing this noise. You know what it sounds like when you take a tire and you turn it on like a very smooth surface to where it sounds like it's like, well, that's what I kept hearing. I was like, what in the heck is this noise? Come to find out, the patient was gritting their teeth so hard, or grinding their teeth so hard, it sounded like there was rubber. So unbeknown to me that this patient had had multiple seizures throughout their life. It is something they've dealt with over and over and over, and they were on high doses of Dilaudid. It just wasn't working. They had no, their teeth were ground flat. There was no contours of their teeth. It just looked like you took a grinder and just went in a straight line on all of their upper and lower teeth. I was like, oh, Jesus. This patient used to have mouth guard protectors. They would bite them in half. And then they had to quit doing that because that became a choke hazard. So ever since then, that's the first thing I get somebody that's either been in a postictal state. I look at their mouth, and that tells you, and potentially you can look at their teeth to see how long that they may have been seizing. If their teeth have been have some grind marks, or they don't have a lot of contour, that unfortunately this patient has had seizures for a very long time, and that is sad. But it's a neurological deficit that they try to fix, but a lot of times it does work with medications, and sometimes it doesn't. You can have those once in a blue moon seizures where somebody has seized and they've never had a seizure before, and they never have them again in the rest of their life. They go through the ringer too, CTs, MRIs, all that other stuff. They're on medication for a while, but it doesn't reoccur. Something happened and they had that electrical impulse, and they started seizing. So for patient, wow, that came out weird. For patients who continue to have seizures, as in status epilepticus, always be prepared to suction that airway. If they start to seize and you're in the back of your truck, get your suction ready. If you have to put it together, make sure you and your partner get everything situated before y'all depart the scene to meet ALS intervention. You want to provide some positive pressure ventilations. If you're able to put them on a non-rebreather and they tolerate it and they're not trying to jerk it off once they've come around, that's okay. Obviously, we need you to transport rapidly because as a basic truck, we don't have the means to fix this. We don't have the medication that we can put on board of this patient to where we're not it doesn't reoccur as much. And again, as soon as you start to recognize that, call for ALS interventions. That's the best thing that we can do is get ALS there, get that IV started, get those medications on board, and then continue transport. That's one of those things that we need to do. So you should be concerned about the patient if they complain of a sudden onset of a headache, they have a headache with fevers, seizures, altered mental status, or the following trauma. So anytime that we go to assess these patients, you don't want to use bright lights. You don't want to check their pupils with bright lights. We don't want to shine it. We want to make sure we get a good visual, but it could trigger at the same time as turn your lights off outside. Those strobes help trigger it. Migraines also, they become very light tolerated, very light tolerant. Sometimes they are intolerant to that. So remember that when you go to transport, you don't want to have your lights on super bright if you have to transport a patient with a severe migraine. Again, apply the oxygen if it's tolerated. They may or may not. You want to support your patient, providing O2 as long as their O2 sats are higher than 94. If they drop below 94 at all, we always want to oxygenate. Carbalinate therapy and methods to mechanically remove the blood clot may reverse the stroke, and it may even stop the stroke if it's given within 3 hours or 6 hours of mechanical methods. If possible, transport to a designated stroke center. Again, you may be able to, if you're a very rural service, you can ask for air transport. And a lot of times those air transports now carry that seizure medication, but they have to know in advance. So you just don't want to call and be like, hey, I have a patient that is, I'm unable to control their airway and they need it. And then once they get there, they realize that, oh, dude, no wonder this patient's been seizing for the last 10 or 15 minutes. And now, or had a stroke, and you've realized that the stroke is, we're an hour and 10 minutes into it. So being forthright with that information and gaining as much information as you can, even if you don't know that time frame for the stroke, letting the facility know the last time that they were noted to be okay versus the time that you received the call will help dictate how that is dispatched to the helicopter service. And the helicopter service can make their own mind up if they want to bring it or not. That's not our decision. Did I hit the wrong button? Okay. So on a seizure, obviously protect them from harm. Always monitor their vitals. You're not going to be able to get good vitals if they're actively seizing. Watch their ABCs. Again, you may have to suction too at the same time if they may have an injury to their mouth or something's stuck in their mouth. You may have to suction as soon as they stop seizing. So if the patient refuses transport, this is where it gets tricky because the patients are going to come out. They're going to, once they stop seizing, they're in that postictal state. We've already spoke about that. We know that state is there. But when they do come around, they have the right to refuse transport. These patients, we don't want to kidnap anybody, but if that is the case, yes, sir, I understand you don't want me to go. But let me reach out to my med control doctor and let's see if we can talk to him. He's the one that's going to make the ultimate decision on what I really, really have to do versus on what you need to do. And I want us to talk this out. If your protocols automatically say contact med control or stop the ambulance until spoken to med control, that's fine. But again, I don't want to be called for that I've kidnapped anybody. Just understand that refusals are that patient's right, but we still have to provide the utmost care for that patient until otherwise told. I have been giving orders before I have to bring that patient in at all costs, no matter what resources that I use. And again, at that point, I may turn around and have to involve PD. I may have to call for another unit because I need more support. All those can take place. It depends on what information you provide the doctor, how serious the patient is, and just also it really depends on the doctor. The doctor may be like, well, all right, well, They wanted to let go. That's on them. Make sure they sign a refusal, and you're like, whoa, they're already gone. So on some situations like that, just make sure you do a excellent report that the patient refused care and they left the scene. They refused me to do, just all those things needs to be documented very, very well, because it can potentially come back on you. Altered mental statuses, see if you can find out what the cause is. Those causes are important. We need to know those causes. Provide spinal mobilization if we have to, ventilatory support, and transport to the appropriate facility. And again, just because it's the closest facility doesn't mean it's the most accurate and the best appropriate facility. So depending upon what your protocols say, I've seen some agencies say that you transport the patient to the closest facility. Well, maybe not all the time the closest facility is the most appropriate facility, but you still need to follow whatever your protocols say. Don't deviate from that, because that will cost you a job. And these days, nobody really wants anything to cost them a job. We have to be very cautious about that. Contact med control, that is a online resource that we can use very, very good. I had to call one yesterday. I had a guy that crushed his hand, 700-pound battery, basically, crushed his hand. I got him situated, got him on IVs, pain meds and all that, but I still had to call because there's a status issue is the reason why I had to call. So Rodney says, yeah, like for here, you go to whatever hospital the patient, yes. So most of the time that is correct, Rodney. It's patient's preference until it is a trauma-related call. At that point in time, I can still trump the patient's decision on what hospital they need to go to. But most of the places do allow those families, those patients to request a facility. Even sometimes when a family member requests a facility, I hate to say is I may honor it or I may not, because that patient is the one that is responsible, not the family member. But at the same time is you just got to be careful. If the family members are very adamant, that's where all their medications are from. That's where they see all 26 of their doctors. Okay, I'll take them 45 minutes away when it's not the closest and the best for them. It's easier to do. I get that. And I have no problems with that. So those are sometimes the way that I'll just transport them that way. So that's the end of the class for this evening. Does anybody have any major questions about the neurological difficulties that we talked about? Seizures, strokes, migraines, headaches, and the recognizing of that. The scene safety and scene size up, y'all should start to realize is going to be the same for every ones that we go through and talk about. It's the same procedure, same process. So beating on that like a dead horse is because that is in your paperwork. That is in your National Registry prep paperwork that you need to do. Does anybody have any questions so far? All right, I'm gonna do this again. I'm gonna beat it as a dead horse. Guys, do not forget that you are required to take tests in this class. You have to take your test. Just because you don't do it doesn't mean you're gonna get access to do it again. If the time has passed, you won't be able to take it. You get one test, you get basically one redo per module. So some of you have not taken any in this module yet. I've had one person take the test from Tuesday night, one. So some of y'all need to tighten up. That needs to be handled. Y'all need to be, nobody has reached out to me about technical issues. Nobody's reached out to me about other issues. This has to be done, y'all. If you will go on to JB Learning, look at your grades, it reflects the zeros that y'all were giving because the time has passed and y'all have not taken your test. So this quiz does not open until tonight, but the last chapter opened at 10 o'clock Tuesday night. I gave y'all one extra day, so that will close Saturday night. That is the only time because that was my personal issue. Some people had weather, some people had some technical issues that I did know about. So I went ahead and just gave everybody one extra day for Tuesday night's class. Now, I took that as on me. But the tests taking, that's not on me, that's on y'all. Again, if you don't communicate with me, I can't help you. There's only so much I can do. So you're required to take these tests to pass this class. A lot of y'all are in some issues right now because you have not taken these tests. So I'm going to give you the code. I'll mute my mic. Quick question, when do we get the grades for the hot topics? I have not issued a grade. I do not have a hot topic for this chapter, for this module. So don't have one. Not sure what you're referring to. Normally get one hot topic per module. There was not one due last week. I have not opened one for this module, so I'm not sure again what you're referring to. So you've had one for module 2, and that was only open for a couple of days, and then it closed. So there was not one that was due last week. Well, we've been in module 3 for a while, so module 2 doesn't count. If you did one and sent it to me, then it doesn't count because that was only for module 2 and it had to be done under certain dates. Please make sure you read the dates that these hot topics are due. A lot of times those hot topics are because I'm a nice guy and I want to help you guys out and I allow some extra points. It's not a requirement. It's not something we're required to do. But I see a lot are struggling, so I offer these hot topics. It is something that you must do, read it. If you don't do it in the amount of time that's there, guys, I'm sorry. I'm not just gonna continue to give points. I'm not that type of guy. But if anybody needs me, after I show the code, I will give you the code and I'll sit here with my mic muted for a little bit. If anybody needs me, you can message me and or we can speak, whatever is easiest for you guys. I hope you have a good weekend. Stay safe. I know it's Mardi Gras if you're down in the South, so please be responsible. I'm a little jealous because I miss Mardi Gras. I'm actually out here, unfortunately, working. So enjoy your time and have a wonderful weekend. And here is your code. Go ahead, Sydney. I have no idea. Let's see here. Sydney, I guess you just have to type me a message. I don't know if you want to do it in an open group or you can direct message me. It's up to you. Rodney, believe I'm on track so far. That all required for the class is to touch. Yes. So that is it. That's it. Simple. I just asked that everybody comes to the class, writes the code down, does the attendance, and takes the test. That's it. But a lot of people are not taking the test, and I'm just using. I'm trying to blast everybody. I don't believe in, criticizing in public to individuals, but yeah, so that's really all I need everybody to do is just take their test. Tuesday is due Saturday, yeah. So Friday, Saturday, yes, sorry, I had to count. Remember, I went to public school, I've used my fingers. So Tuesdays is due Saturday, that is correct, and tonight is due by Sunday. So remember, they close at 11:59. If for any reason you try to get on at 11 o'clock, 11:15 to take the test, it will not allow you because there's not enough time. Share. Open up another screen. Mario, hang on one second.